So during the presentation, go ahead and mute your microphones. And at the end, we'll go ahead and do a question and answer period and open it up to each site. And we look forward to having you join us during the question and answer period. And I'm going to invite Jamie up to speak for us now. Yep, and now it's trying to figure it out, back to figure it out. Okay. Let's go. Ooh, look at that. Breathe. There you go. Okay. All right. Anything else?
Do you want me to just speak right here into this?
Okay
yeah,
with you?
Yep, that works for me.
And I can hear you, and so we'll let you know if we...
Okay, all right. Let me know if you guys have any trouble hearing me or at the distant sites. My name's Jamie Mark. As Cindy said, I'm a nurse practitioner, and I've been working with deep brain stimulation and patients with DBS now for about the last 13 and a half years here in Spokane. I work at Northwest Neurological, and we are an adult neurology clinic with specialization in movement disorders. And amongst that group of disorders, Parkinson's disease is one of the most common, if not the most common, disorder that we see in our practice. And so today I was asked, I've come before and spoken about deep brain stimulation. And today I was asked to talk about the difference between STN, which is subthalamic nucleus, and GPI, which is globus pallidus interna. So the two different topics you hear about, STN and GPI, it's not two different types of surgeries or procedures. It's two different areas in the brain. So when you hear that referenced, the surgery is done exactly the same. It's the same technique, but our targeting, the area in the brain that we're targeting, is just a little bit different. And that's how we set up our protocol and our targeting based on the structure we're looking at implanting. So today I'll talk about and show you where they are in the brain and some of the differences we've learned about each location. And to start with, I have just a little general review on deep brain stimulation for those of you who it's just new in general to go over a little bit. And then when I'm all done, I'm happy to answer any questions about deep brain stimulation, GPI, STN, and even if you just have some general questions about your Parkinson's disease that doesn't have to do with surgery, we can go over those as well, because I still do that in my job as well. So to start with, if you look at deep brain stimulation for Parkinson's disease, it was actually first FDA approved in 2002 with both the STN and the GPI. So it's not that one target is newer than the other. They were both FDA approved at the same time. Essential tremor, which is a movement-based tremor, and Parkinson's tremor, there was an approval even earlier than that in 1997 for a different area of the brain called the VIM. It's the ventral intermediate nucleus. And so back in 1997, if we had a patient with Parkinson's disease that was tremor predominant, the tremor was really disabling or difficult for them, they may have been implanted in the VIM. So that's another target within the brain you might hear about. Since the advent of STN and GPI, it would be very rare, and at our center, very, very unlikely we would implant a Parkinson's patient in the VIM. The two targets we tend to implant are the STN or the GPI, and at our center, our prevalence or history has really centered more around the STN, just to give you a little background. But they've really been around for a number of years. You know, a lot of times Parkinson's patients come into me and they talk about DBS and how new it is and what a new treatment. And I put this slide up to point out it's actually been around and FDA approved for a number of years. We started in Spokane actually under research protocol implanting the STN back in 2000, and that's right when I joined the team. And so we've actually been doing it for a number of years, so I just wanted to highlight that. So this is the slide where I wanted to point out the anatomy within the brain. I don't know if I have a pointer. No, okay. I'll kind of go over to the slide and show you here in a second, or over to the overhead. The STN and the GPI are actually within millimeters of each other, although they're completely separate nuclei in the brain. They're not that far apart from one another. So when we reference them, it's important to realize, even though they're shown separately in this diagram, that they aren't that far in the brain. They are both deep structures within the brain, down below the thalamus. One is on the inside of a structure called the internal capsule, that's the STN, and one is on the outside of the internal capsule, that's called the GPI. So I'm going to move over to the screen and just show you some different reference points in the brain. Do you have one? Oh, that'd be great. Thanks. Okay, Cindy's going to help me out here. So in the top slide, you can see the green kind of, circular area. That's the STN. So when I'm referencing STN, that's a particular nucleus. The big red circles just medial or to the middle of that are called the red nucleus. And then you see those fibers kind of projecting up above the STN. Those are different fibers, maybe projecting down actually towards the GPI. And in STN stimulation, we might actually stimulate those fibers that actually project into the GPI and get some benefit in utilizing GPI-like benefits or improvements. If you look at the bottom slide, you can see the GPI, which is kind of a more elongated nucleus. And that's specifically the globus pallidus interna. The structure just above it that's kind of in the green is the GPE, the globus pallidus interna. So the globus pallidus nucleus is separated into interna and externa. And as you'll hear in my talk today, the basis of stimulation and this surgery is getting the lead in the right location. So whether we're talking about implanting in the STN that's up above or the GPI that's down below, it's important that we get the lead in the right spot. If we do not, patients aren't going to get much benefit, and they could potentially get a lot of side effect. So this is just kind of a neuro anatomical slide to just kind of show you a little bit of their shape, what they look like, and kind of what's around them within the brain. Thanks, Cindy. Appreciate that. Okay, so in talking about deep brain stimulation, the other thing to talk about is, when do we introduce deep brain stimulation to patients? When are patients hopefully being introduced to this therapy? Because we've learned over the years it's really critical that we introduce the therapy earlier than what we used to do. Back when I started in 2000, we were doing this surgery experimentally. We weren't exactly sure who it would benefit or how it would help people. We had obviously some general ideas, but we weren't exactly sure when we should recommend it or who should have it. And, most patients weren't real interested in getting something put in their brain. So we didn't have a line at the door waiting to get the surgery done. So it tended to be reserved for patients who were more severe in their disease. And I think the biggest thing I've learned over the years that I've been working with DBS is that we should not be waiting so long. We should be doing this earlier. We can give people more benefit if we implant earlier. And you'll hear, I'm hoping this next part of my slide will come up. There we go. You'll hear with DBS this talk about window of opportunity. And the studies that were done with DBS initially coined that as advanced symptoms. Now, I kind of have a hard time with that terminology, because in my mind, when I think of advanced, I think severe. I just feel like the two go along together. And so I want to point out, advanced doesn't mean severe. Advanced actually means about 5 to 10 years after diagnosis, we should be looking at this as a possible treatment option for patients. Oh, thank you. Thanks. So when it says advanced, keep in mind that was the terminology used in FDA approval for the surgery, but by no means do we mean severe. We mean, the more moderate stage. Now, people often say, well, why don't you implant early? Why don't you implant here where it's mild? And there's a couple of reasons. One, people, we're starting medications for them. The medicine's usually working very well, and they don't need it at that point. As long as medicine's working well, I think we'd all agree that's probably the option that we would consider. The other thing is, when we're diagnosing someone with Parkinson's disease, it can take clinicians more than just a visit or two to determine what they have. Parkinson's disease, unfortunately, we still don't have really good objective tests, scans or blood work or things like that, to definitively say what we're looking at is Parkinson's disease. And our best testing tool is really giving people medicine and seeing how they do with it over time, and watching people and seeing how they do. Someone with idiopathic Parkinson's disease usually has fairly typical presentation of symptoms: tremor, slowness, rigidity, difficulty with walking and balance. And the medication is usually helpful for some, if not all, of those symptoms. And then as the disease progresses, we certainly see more things. But in the more atypical forms of Parkinson's, what you might hear of as atypical Parkinsonism or Parkinson's plus syndromes, we often see more atypical symptoms present early, and that might give us a clue that we're not really looking at idiopathic Parkinson's disease, but rather an atypical form. So we need to be watching patients and studying them and talking to them, sometimes for a couple of years before we determine this is in fact, idiopathic Parkinson's disease. And again, that's part of the reason we don't implant really early in the diagnosis when someone's just been symptomatic for 2 or 3 years. We like to wait for some time and make sure it is in fact Parkinson's. When we look to introduce deep brain stimulation, people are often having unexpected off periods. And you're probably all familiar that when we say on versus off, on means your medicines have kicked in, they're functioning well, you're doing the best you do in your day and the medicine's working, and then your off time is when the medicine's worn off and you're more symptomatic and you're not functioning as well. If someone comes to us and they're 3 or 4 years into their Parkinson's, they take their medicine 3 times a day, they're on all day long, they're functioning at a high level, again, we're not necessarily going to be considering DBS at that time. However, year 6 or 7, when they come in and they say, I'm now taking the medication 6 times a day, it only lasts for 2 hours, then I'm wearing off, and they're kind of on that roller coaster of on time and off time, cycling throughout the day, we're certainly or should be looking at DBS at that point. Also, when people start to become dyskinetic from the levodopa, the kind of choreiform twisting, rolling, writhing movement, sometimes that's an indication that we need to be looking at DBS. The other that we've had in a few instances are patients who maybe haven't tolerated the medicine really well, and over the years they need to take more medicine to get enough of a response in their symptoms, but unfortunately they're having such intolerable side effect, they just can't increase the dose high enough. So we have implanted very successfully a few patients that are maybe only 3 to 4 years after diagnosis. We're very, we feel very safe with the fact that they do in fact have Parkinson's disease, but they're not tolerating their medicines well. They can't increase the dosage, and therefore they're not doing well with their Parkinson's. And in some of those patients, we have implanted early due to that specific example. This is a really important slide, and there's a couple extra pieces along with this that I'll go over today. I think I cannot stress this enough for patients looking at DBS surgery, and even after people have had DBS surgery. There are certain things that the surgery does a real good job for, and other things where it doesn't help as much. Now, I do disagree with some of these over here, and we'll talk about them a little bit further. But if we look at what responds well to DBS, slowness of movement or bradykinesia, tremor, rigidity, dyskinesia, those things we feel that with a good candidate, a well-placed lead, and then proper management of the programming and medicine, we should be able to get very good response in. And the nice thing is, for many patients, that holds for years and years, the response in those symptoms. So you can expect a good response in these symptoms with DBS. The things that are I don't know that I would use the term necessarily resistant to DBS, but less likely to be helped. We certainly do not expect that we're going to help speech. And for a Parkinson's patient, that is often one of their key complaints coming in. Their voice volume's low. Other people are having a hard time hearing them. Will this surgery make my speech better? We do not expect to make it any better with surgery. And for some patients, depending on the stimulation, we worry we might make the speech a little bit worse, and we might have to adjust the stimulation to try and minimize that. Balance is a difficult one, and gait overall is difficult because, again, that's often a common concern of patients prior to DBS. They're saying, I'm not walking very well and I'm falling. Will DBS do that? And I always say to patients, in general, I'm not sure, unfortunately, prior to surgery. I can't often give people a good answer to that specific set of symptoms. I can tell you, having been involved with probably over 350 patients, I've seen instances where, yes, freezing gait does improve, or a person's falling a lot less in some people. And then I have other instances where patients say, I don't think it's helped my walking that much. So for some people, I think it can get better, but not for everyone. And I don't think we have good parameters or guidelines right now to say, well, who is it going to get better in? How can we know? I will say that it really comes down to that concept of on time and off time. The things that improve when you take your medicine and you kick into an on state are the things that are most likely to improve with surgery. So if you're someone that, in an off state, you're freezing, you're not walking as well, you're having more difficulty getting around the house, but then you take your medicine and you say, gosh, I'm pretty normal, or I do pretty well. Well, then maybe because the surgery we expect to give you more on time, maybe we will improve your overall hours of on time, which then in turn improves your ability to walk or to ambulate. I've had a couple of patients as well, when we look specifically at this question of balance, who have been falling, sometimes upwards of 10, 20 times a day prior to surgery. They may be falling during their off time. They may be falling because they're very dyskinetic. And I've had patients after surgery, by improving their on time, reducing their dyskinesia, that fall rate really reduces significantly. So again, the balance and freezing gait is a kind of wait and see, unfortunately. In some patients I've seen really good benefit, and in others they say, it's about the same. Certainly, as someone has had DBS longer and longer, and their Parkinson's has progressed years down the road, these are the issues that I'm dealing with in the clinic. I'm not dealing much with tremor, dyskinesia. Those things are all under really good control. But people are coming in talking about their walking and their balance being difficult. So it's a couple of symptoms that we're kind of battling, trying to get the best control that we can. And then if we look at the things that are not improved by the DBS, the big one here is really dementia or memory difficulty. We do not expect to make memory better with DBS. And that's in part why we screen very carefully our patients prior to surgery to make sure that they're doing okay with their memory and thinking. Because the concern is, if someone has some degree of dementia going into the surgery, that we could potentially make it worse. And by doing the surgery, we don't want to make anything worse. So it's not expected to improve memory. Depression, it's really not expected to improve someone's mood. However, I can tell you, when we were doing our research starting back in 2000, we did really extensive psychological testing prior to the surgery, and then 6 months after. We also did memory testing at those intervals as well. And one of the things our neuropsychologists found was that almost across the board, patient scores for depression and anxiety did improve. Now, I don't think that really had to do with just the surgery of implanting the leads, but the fact that people were taking less Parkinson's medicines, their symptoms were under better control, they were able to be more active and have better quality of life. And I think for any of us, if that happens to us and we can function and do better in our day, we're of course going to be happier. So I think it was due to that. But directly, it's not meant to improve mood. And then psychosis, in this instance, they're talking about things like hallucinations and whatnot. We don't expect to make hallucinations any better. However, if people are hallucinating because of the amount of Parkinson's medicine they have to take to be able to move around, after surgery, if we can lessen the medicines, I have had instances where we can, improve the hallucinations. But again, at baseline, we're not expecting we're going to make that any better. And then constipation, that's kind of just a symptom we battle with Parkinson's throughout the disease. Again, if the constipation is related to some of the medications being taken and we can reduce those, we could maybe make it better. But it's, again, not something we really expect to improve with surgery. As I said earlier, two kind of take-home pieces I would want everyone to leave with today, more important than just STN versus GPI. One is, again, to think about what am I like when I'm off and what am I like when I take my medicine, because those symptoms are the ones that would be expected to improve with DBS. And then the second thing is to think about your best on time and what you're like. With DBS, we don't expect to make people any better than their best on time. And so if your current on state isn't very good, we've unfortunately probably waited too long to talk about DBS and implanting someone, but we don't necessarily expect to make it much better. In some of the recent studies they've done, they have shown 20 to 30% improvement in the UPDRS, that Parkinson's rating scale, in best on state. So, I wouldn't say it hasn't happened, and I've certainly seen instances where it has. On average now, the thought is we improve on time by about 5.2 hours during the day. So that's pretty significant. If you right now have 4 to 5 good hours in the day and you could double that, it's a pretty significant estimate. But again, looking at what you're like in the on state and getting more of that time, and does that seem like a good benefit in considering DBS as an option? So if we look at who's a good candidate, I've kind of touched on candidacy a little bit. There are just a couple basic keys to who's going to do well. It's important that you've had a good response to dopaminergic therapy. The main medicine we're talking about there is Sinemet, also known as carbidopa-levodopa. It's also in a medicine called Stalevo. So, people often, when I'm evaluating them for surgery, they'll say, well, my Sinemet, no, it's not doing much for me, or it's not working well. Well, that's the case for most people looking at DBS. They wouldn't be looking at surgery if it was really helping. So what we're talking about is a historical positive response. Back when you started the medicine, did it help you? In the first few years, 3 to 5 years of your disease, did it help you? It's important to know that patients have had a good therapeutic historical response to levodopa, because again, we feel like if you've done well with the medicine, there's a better likelihood you will do well with surgery. Some people liken the surgery to electrical medication, and they'll say, things like it's going to do for you what the medicine does. So that historic response is important. And then sometimes we'll bring patients in and do an on and off evaluation, because if it's a patient that's been in our clinic for a number of years, we probably caught them in the on and the off state, and we know what the medicine does for them or how well they're doing. But if it's someone that is new to us, we'll oftentimes do an on-off evaluation where we'll have them hold their medicines the day before. We evaluate them first thing in the morning with their medicines off for 12 to 16 hours. See what they're like on exam, have them take a dose of their Parkinson's medicine, and then evaluate, maybe 45 minutes later, so when it's kicked in, and see what the improvement is. Some insurances are requiring this step for insurance authorization, so sometimes we do it as part of that as well, and they want to see at least a 30% improvement in the off to the on state, again, because that's a predictor of who's going to do well with the surgery. And then as far as this surgery being successful, it comes down to really 3 things, as I kind of have already touched on. Selecting an appropriate candidate, getting the lead in the right location, and then post-operatively managing the medications and the stimulation in follow-up visits. Those are the 3 keys. Okay, so now let's get on to our talk specifically about STN versus GPI. Now, as I said earlier, our site is more predominant STN, although we do some GPI implanting depending on the patient and depending on the presentation of symptoms. You'll find, or I find, I guess, going around and talking nationwide about DBS and talking to other centers, that we all kind of have our own preferences at our surgical center as far as if we shave the head or not, and the type of incision we use and the type of suturing. And we all kind of do things the way we do them because of years of experience and figuring out what is successful for us. It doesn't mean that any center is doing anything wrong if they do something differently than us, or if we're doing something differently from them. A lot of it's just personal experience and what we find gives the best outcome for each individual patient. If you kind of tallied most of the DBS centers across the nation, there is more predominant STN placement in general versus GPI. However, if you went to OHSU in Portland, they tend to implant more GPI than STN. And down at UCSF, San Francisco, they have kind of a half and half kind of situation. So depending on where you go and who you talk to, you'll hear different things about we implant STN versus GPI. If you look at the STN nucleus, as we were looking at earlier with that picture, it's a much smaller target. It's about the size of a bean. I've even heard as small as a pea. The largest I've heard is the size of an almond, but it's a pretty small structure we're targeting deep in the brain. It's kind of elliptical in shape, and so that determines some of the angles that we approach with our targeting of the STN. And the good news about that, I mean, number one, you need to have a skilled surgeon to be able to hit it because it is smaller, which we fortunately have two here in town. However, with the lead that we use to implant, we can often stimulate a large portion, if not all, of the nucleus, which could be very beneficial. So that's one of its positives. If you look at GPI, it's a larger target. It's kind of a little bit more columnar or spread out. So some people in their mind, some surgeons think, well, it's bigger, so it's maybe a little easier to hit. But now we're finding within the GPI that certain areas maybe do certain things. So in the GPI, it's not just about hitting the GPI in general, it's about hitting the right spot within the GPI. The structures that are higher up in the nucleus in the GPI, we think are better for relief of slowness of movement, inability to move. And then the structures deeper in the GPI maybe are a little bit better for rigidity and suppressing dyskinesia. So we try and hit a middle ground between the two for the best lead location with the GPI. You may, and we elect to, in the GPI, use a more widely spaced lead where the electrodes are further out from one another so that we can span a larger area with it being a larger nucleus, a larger target in the brain. So if we look at the two individually and we say, well, what's better about STN? What's better about GPI? In general, we think that if people are tremor predominant with their Parkinson's, or they have a lot of tremor, the STN is probably a better target, probably does a better job at controlling tremor. And this used to be a thought, for years and years. More recently, GPI is kind of gaining a little ground because it's looking like a good source of tremor control as well. But STN is really still thought to be the best at tremor control. With this surgery, one of the big benefits is the potential ability to reduce a person's medication. And statistically, what I've seen in our clinic is with STN, reducing the medicine about 40 to 50%. Some patients don't reduce quite as much, and some patients reduce a little more. The goal with this surgery certainly isn't to get off your medicines. That's not what is expected. But for a patient not being tied to the clock or their watch on when am I going to take my next dose? Oh gosh, I'm out of the movie theater and I forgot my medicine at home. It's one of the nice benefits with this surgery is the ability to take less medication, take it less frequently. Within the STN, when we're stimulating, we can possibly induce or create dyskinesia from stimulation, and that is kind of a negative and a positive. A negative because, I don't want people to be horribly dyskinetic, and we're trying to make those better oftentimes in doing this surgery. But it can allow people kind of an improved on state, and it can easily tell us if we're in the right area programming. It's a real positive if people get dyskinetic with programming that we're right in the right spot. And then When we look at memory and thinking, if those of you have kept up on DBS in the literature at all, you'll hear, about memory and are there concerns about patients' memory after surgery. And one of the areas when they did a head-to-head trial looking at STN versus GPI, they did see where with the STN, a slight increased predominance of difficulty in the particular area of verbal fluency. And that is word finding, for example. And so that's where you know what you want to say, but you can't think of it right then, or memorizing a list of words might be difficult, remembering someone's name, a phone number, things that you should know, but not being able to come up with them right then. They think with STN that could be a little bit worse than with GPI. Statistically, it was very small, but maybe, potentially a negative for STN if we're looking at negative versus positive. So if we look at GPI, what are the pluses or minuses? Improvement in slowness or akinesia means inability to move has been well demonstrated in the GPI. I think we definitely achieve that within the STN, but sometimes people are a little bit limited by the dyskinesia that we could potentially produce in the STN, where in the GPI, we don't tend to induce or cause dyskinesia, but we actually suppress it with the stimulation itself, even before medication reduction. However, the medicine reduction in the GPI is significantly less. This 18%, however, is positive because we used to think with GPI we really couldn't reduce medicine at all, and now they're finding, surprisingly but happily, that we can actually reduce medicine on average about 18% even with patients implanted in the GPI. So if I have a patient who's coming to me and they're taking quite a bit of medicine, or they're having difficult or intolerable side effect to their medication, one of the things I'm keeping in my mind with implant is, well, which target will allow me to reduce medicine more, knowing that down the road, even though I've reduced it after surgery, 5, 7, 10 years down the road, I may have to increase it again somewhat to help with their progression of their Parkinson's disease. So that's something we keep in mind, and probably why STN wins out for a lot of people is that medication reduction component. So the study, and this is if you have the paper that I handed out, has a little bit more detail. But the biggest study that's been done to date was 299 patients across 13 centers, almost equally half were STN versus GPI. And when they did this study, they were really looking at, and we all really wanted to know, what's going to be the difference between the two? What's going to tell us as a clinician when we should implant one nucleus versus the other? How are we going to better know what to do for our patients? And unfortunately, or fortunately, whatever way you look at it, the study didn't provide a whole lot of information or difference between the two sites. The motor function improved with both STN and GPI: tremor, slowness, stiffness. Both sites had equally as good of improvement, even looking at it 2-3 years after implant. There was a difference in medication reduction. In the study that was done that I'm referencing here, the GPI was 18%. The STN wasn't quite as high as the 40-50 that we've seen a lot of the time in clinic. It was 32%, but still statistically a much more significant medication reduction. If you look at adverse events, bleeds in the brain or infection or things that are concerning with this surgery, there was no statistical difference between either target as far as safety or which site was safer or less likely to cause an adverse event in a patient. They were both found to be equal. And in the adverse events that were documented, 99% of those resolved by 24 months post-op. So in the things that were reported in both groups, fortunately almost complete resolution of those adverse events. So when we look at the two categories and what is right, or what would we implant for each individual patient, again, I don't think we necessarily have from this study a clear idea of one truly being better than the other. I think they're good in their individual respects. And again, at the end of the day, it comes down to the surgeon and their comfort level implanting in these different areas of the brain and hitting the target. We have to hit the target. And so one surgeon might be more experienced and comfortable with GPI, and another one might be STN. The one reason I would say, and why we have implanted a couple of patients GPI here in Spokane, is if we had a patient who came to us who did not have tremor, really had never had tremor as part of their disease, they had real wide swings between being on and off. So in an off state, they were real stiff, frozen, unable to move. And then when their medicine kicked on, they were really dyskinetic. And in younger male patients, that's kind of another category that we're seeing. Those people might do a little bit better with GPI. So that's a consideration that we're certainly keeping in mind. But again, at the end of the day, we've got to get that lead in the right spot and pick a good candidate to get a good outcome with this surgery. And those are the most important criteria. I think I've drilled this into you time and time again, so I won't go over that again. And that's it. That's my portion, just going over the differences. So now I'm happy to take questions from whomever, wherever, I guess.
Yes, I know who Laurel and Hardy are. And thank you.
Okay.
There we go. And I'll come. Do you want the list? So I'm going to go from memory really quick instead of looking at the list. And we're going to start with our outlying locations. And since it's the one I remember off the top of my head, Lewiston, if you'll go ahead and unmute your mic and tell us how many people are there today and let us know if you have any questions.
Okay, Cindy, I'm not aware of any questions we've got. Jamie enjoyed the presentation. It's very helpful again. We can't just call us Lewiston, though. We're Clarkston and Lewiston down here.
Whoops, sorry.
And we have 20 people here today. Thanks.
Great.
Thank you, everybody, for joining us. Lewiston and Clarkston. Okay, let's see. Billings, Montana, Deaconess Billings Clinic.
We have no questions and very informative. Thank you. We have 4.
Thank you for joining us. Do you have that snow that we heard about?
No, it's just awfully wet so far.
Okay, well, I hope it stays that way for a little bit. I don't know about you, but I'm not ready for snow yet. Coeur d'Alene, Kootenai Medical Center. And for some of these sites, Columbus Day might be looking. We'll go ahead if Coeur d'Alene, if you're there and you want to hop in later, that's good with us. Colville, Providence, Mount Carmel. And Dayton General Hospital. Grangeville, Idaho, Syringa Hospital and Clinics. And Kennewick General Hospital.
One person, no questions. Very nice presentation. Thank you.
Thank you for joining us today. I don't see you marked, but Miles City, Montana. Are you there today?
Yes, this is Miles City. We have 7 of us today, and we have one gal in our group that has had this done in the last 2 years. And it worked very well.
Thank you for joining us. Good. Thank you. Do you have any questions today?
No, I don't think. Good.
How do you know which the GBS or whatever, which one that you've had?
Well, that's a good question.
Yeah, we're not sure which. We
where
feel
were
like
you implanted?
In Billings, Montana?
Okay, by Dr. Goodman?
Yes.
I believe, because I see a couple of his patients, I believe he implants in the STN. Do you know the
I
type
would say
of...
that by the description you had, that's what's telling me.
Yeah. oftentimes patients will come to me, maybe they've moved to our area, or, people maybe live in Spokane for the summer and then somewhere else in the winter, and I'll inherit them. And that's always something I want to know, is because we program it a little differently, potentially, depending on the lead location. So certainly I would think, because it is good to know, it's a good piece of information to know. You could call your surgeon's office. In addition, depending on what type of battery you have, which my guess is if you were just implanted 2 years ago, you have the newer generation battery, it's probably programmed into your battery. So if anyone interrogated your device, it would say specifically on their STN or GPI. So the next time you go to a programming session, you can ask.
Thank you.
Mm-hmm.
Very good.
This is City. Moses Lake.
There are 8 of us here today, and we have 2 questions.
Welcome.
I was wondering what some of the other adverse effects are.
Talking to this.
That's okay. I heard you.
Closer. Okay.
You said,
thank you.
what are some of the other adverse events?
Yes, you mentioned bleeding only.
Sure. So it's a very good question, and whether you're being implanted in the STN or the GPI, the relative risk we believe to be the same. What I always tell patients is that the 2 biggest risks, and when I say that, I don't mean statistically they happen very often, but biggest meaning most concerning to me, number 1 would be a bleed in the brain, and number 2 would be an infection in the brain. And so I always encourage patients, if they're not at our center, if you're going somewhere else, to talk to the neurosurgeon and ask them individually how many patients you've implanted that have had a bleed, and how many patients that you've implanted have had infection. Those are 2 things you definitely want to know. Now, when we talk about a bleed in the brain, the bleed could potentially be deep down where we've put the lead, or it could even be on the surface, or what we call cortical. But obviously we count them all. A bleed is a bleed. But sometimes how the bleed is differentiated is in what we call symptomatic versus asymptomatic. A symptomatic bleed means that the patient had symptoms from that bleed in the brain. And an asymptomatic means, well, the patient actually presented no symptoms, but postoperatively, we very often get a CAT scan or an MRI to look at our lead placement, and sometimes we just happen to see it on scan. So you want them to categorize all bleeds in total, those that are asymptomatic, those that are symptomatic. Nationwide, the risk of bleed is less than 2%. At our center here in Spokane, less than 1%. And so if you're going to someone and talking to them, I'd certainly want them falling in that category. And then when we look at infection, the nationwide average is about 5 to 7%. However, most all of those occur in the chest where the battery sits. We make a little pocket for the battery, the generator. And most all infections occur in that site. So again, you want to differentiate, have you had a person with an infection in the brain, or have they happened in the pocket, and how often? Infections, fortunately, don't tend to cause any long-lasting problems, but the difficulty is if you have one, you will have to get treated with antibiotic. There's no doubt about that. But we might have to remove part or all of the device. Foreign objects in our bodies attract bacteria very easily, and once they've got bacteria there, the bacteria spreads very easily. And so in order to keep the infection, if it starts here, from going into the brain, sometimes the surgeon will take out part or all of the device to avoid that. Now, it doesn't mean you can't be re-implanted. We've done that a number of times where, if a patient's device had to be taken out for whatever reason, once the infection's cleared, we might go back 3 months later and re-implant if they want it and if they need it. But that's certainly, those are kind of the 2 biggest concerns that you want to be talking to your surgeon about. The other things we see postoperatively in some patients are periods of confusion or sometimes hallucinations, and that can be dependent upon how stable the patient is going into the surgery, if they already had some of those difficulty, how they tend to do with pain medicines. And then sometimes we have patients that have that after surgery, and we're really kind of surprised because we didn't expect that they would. Fortunately, for most people, that resolves within a week or so, but it certainly can be hard on the family and the patient if they didn't know that that was going to happen. So those would be the main things that we see happening after surgery that we try and, minimize or get control of. There's also the potential to have side effect from stimulation, but that can be changed or adjusted by changing or adjusting the stimulation or turning the device off. So when you hear of adverse events, it's good to classify, well, did this happen because of the surgery itself, or is this a side effect of stimulation?
And then you're welcome. Did you have one more question at that site?
I have a couple of questions. My husband has a pacemaker.
Mm-hmm.
So you were pointing to this area of where the batteries would be, or the low mechanism. Will the pacemaker batteries interfere with the stimulation batteries?
That's a very good question. Actually, we can implant. It is okay to implant in a patient who has a pacemaker. The rule is that we want our battery, our DBS battery, 8 inches separate from the cardiac pacemaker. So we have 2 batteries available now that are dual channel, meaning both leads get tunneled down the same side of the head and plugged into one battery. So the pacemaker battery typically is in the left chest, and we could still put our one DBS battery in the right chest with both leads going to it. Or there's even an extension possibility. I've had patients that have, the leads coming down in individual batteries on both sides, because that's how we tend to implant more of the time. And I've had patients that have required a cardiac pacemaker that they tunnel and put the pacer with an extension wire down in the abdomen. So there are definitely ways to get around that.
How long do the batteries last?
So we have 2 what we call primary cell batteries, and those last about 3 to 5 years, depending on the settings we end up programming in. And then we do have a rechargeable cell battery, which some of our patients have, and that will last 9 years. The main difference between the 2 is the rechargeable requires more patient involvement because you have to recharge it to keep it going, but that one will last longer.
Do you recharge that similar to how you recharge your pacemaker?
Yeah, the recharging system is plugged into a wall, and that's charged, and then you unhook it and you apply this little kind of disc-like object on top of your battery and charge it up. And it's usually not too extensive. I mean, most of my patients with Parkinson's are charging themselves a total of maybe 4 to 6 hours every 10 days. And you could do it every day for an hour or do it all at once. It's real generous as far as how you charge. It's real flexible. I can tell you for most patients with Parkinson's, we aren't implanting the rechargeable to begin with, unless there's specific reasons why we think we would need to. For example, them having a cardiac pacemaker or whatnot, we might consider that.
Okay, I have 2 more quick questions. Is that all right?
Yeah.
Do you notice this procedure immediately after you've had it done, or is it, you do?
Well, no, I was just going to say that's a very good point, and something that I try and remember to tell my patients over and over with, because when you're a patient and you're thinking about this, a lot of thought goes into it. And once you have the surgery done, you're relieved to have it done, and you're just ready to be better right away. And really, the bulk of the work comes after a person's had the surgery with programming and medication management. It can take a good 3 to 6 months for people to get some kind of level of stability. Now, sometimes just from going in and putting the leads in the brain, people experience what's called a thalamotomy or pallidotomy effect or benefit, where they get some improvement in symptoms for this kind of honeymoon period of a few days, and then they just kind of go back to how they were. So sometimes people come into the initial programming with me and they're real discouraged because it was helping and now it's not. But until we turn the devices on, get some electricity going through them, get some programming done, it can take a little time to see some benefit.
Okay, I have one more. My husband is 72. If he had chose to do this in the next year, how long does this procedure last? Is this a lifetime procedure or?
So do you have any concern? Are you in part talking about his age? Do you have concern with his age and getting it done quickly because of that?
No, I don't even know why I said his age.
Okay.
I mean, no, I guess that doesn't even matter.
Okay.
I was just thinking he's totally controlled with medications at this point. And our neurologist said, he's doesn't seem to be ready for this procedure at this point. But let's say in a year from now, if he elected to do it, is it something that would last him?
Sure.
Is there a time limit on it?
Yeah. Again, very good question. People very commonly say, how long will this work? How long does it last? We've been implanting people in the U.S. with this for 15 years. In Europe, they've been doing it for 20 years. And I always say to patients and their families, there's no time period where I expect it to stop working or that we turn it off and we just leave it off. Because most patients continue to get benefit from it. Now, it is important to recognize that this surgery is not curative. It doesn't cure the disease. It doesn't slow the progression. And so at baseline, you still have a patient with Parkinson's who's progressing over the years. But with the DBS stimulation, I'd say most of my patients are doing far better with it than without it. 5, 10, I have a couple patients now 13, 14 years out. And sometimes I've kind of wondered for my patients who've had it for years, gosh, how much is it helping them? And I've had a couple of patients where accidentally a battery has gone off and you see the marked difference in how they do. And you recognize, gosh, even in people who've had Parkinson's for a number of years, it can still be helpful for them years after they've been implanted. So there really is not a shutoff time. And again, kind of the key to the success is implanting someone early and not waiting too long. If you wait to the point where someone's, fairly disabled by the disease, you can't get as much benefit out of it as you would have if you would have done it a few years before that. So as long as you're kind of in that good window of opportunity, we expect it to be effective for you for a number of years.
Does it look like there's a cure in sight?
That's a good question. They're working on a lot of different things, and I try and always encourage my patients because I think with Parkinson's sometimes it gets a little discouraging thinking, well, is it just the medicines and the surgery? What else is out there? There's so much research going on. They're still looking at stem cell. They're looking at viral vectors. They're looking at all kinds of different treatments that could, at a minimum, be neuroprotective. I don't know that any of them yet are saying for sure curative, but they are working on a lot of different procedures, medications that hopefully will be neuroprotective. And in the next, I would hope, 5 to 10 years, we'll see some major changes in the treatment of this disease.
Thank you. Did you have a question?
Yeah, I have one question. My main trouble is stiffness in the legs in the morning. I call it the Tim Conway shuffle. And will this procedure help it any?
So you have that in the morning, and then when you take your first dose of your Parkinson's medicines, does it get better?
It gets better. I loosen up. But it just feels like there's a big restriction there.
Yeah, and rigidity is one of the most common symptoms that people complain of and come in with. And yes, rigidity is something we often improve with DBS. Now, again, the big criteria is currently when you take your Carbilevo or your Parkinson's medications, does it get better? Because the things that get better with your medication are the things that most likely are going to get better with the surgery.
That answers my question. Thank you.
Okay.
I have another question. Oh, we have one more.
Do you have to push that?
I think
Okay, can you hear me?
Uh-huh.
I've been told about pedaling for Parkinson's. It has a deep brain stimulation effect, and I've been doing that.
Oh, good. Where do you live?
Moses Lake.
Oh,
I live
Moses
in
Lake.
Moses,
Oh, great.
Moses Lake.
Wonderful.
And the results I've noticed were the leg stiffness really improved, and my right arm just was more loose and, not as rigid.
Wonderful.
So is that the same stimulation as the implant?
Well, no, we don't think so. People say, well, and that's again another good point. How does DBS work? What does it do? Well, the honest answer is we think we know what it does, but we're not exactly sure. The reason DBS was even created or invented years ago in Europe, a very talented surgeon by the name of Dr. Benabid, what we used to do is we would go in and lesion a part of the brain, literally burn part of the brain to destroy the area to provide improvement in symptoms. And oftentimes people say, oh, Michael J. Fox, he had DBS. Well, he actually hasn't had DBS, but he had a thalamotomy where they went in and burned part of his thalamus intentionally to improve symptoms. And so when they would go in, they would stimulate the area first, and they started recognizing, gosh, that patient's tremor's improving even before we really destroyed the area of the brain. So that's how stimulation came about. We do not believe it affects dopamine or neurotransmitters as exercise or medication might, but rather the basal ganglia, which is the whole circuitry involved with this lack of dopamine that gets kind of out of whack from the reduction of dopamine. The STN and the GPI, we think, within that circuitry don't know how to behave or what to do with that lack of dopamine, and so they're kind of overactive or firing at an abnormal rate, causing these motor symptoms. And so we think what stimulation does is it either overrides that hyperactivity to kind of calm it down, or it might recreate a more normal cell firing pattern to provide improvement in symptoms. So we think it's actually doing something different than affecting dopamine or epinephrine or cortisol or those kinds of things that we elicit in other ways. I'm excited to hear about that you're doing that program. We just recently learned here in Spokane that we're going to get that program at the YMCA for Parkinson's patients. So it's pretty exciting.
Oh, good.
Yeah.
Okay, thank you.
Uh-huh.
I'll push that. I'll tell you.
Thank you very much, Moses Lake, and all the good questions. Pendleton, Oregon, actually, they might not be there today because it is the holiday. Port Townsend, Jefferson Healthcare.
Hi, we're here. There's 7 of us, and we have a couple questions.
At Pendleton or Port Townsend?
We're Port Townsend, Jefferson Healthcare.
Thank you.
Do you want to ask, Fabienne?
Sure.
Hold on, please.
I was wondering, beside bleeding and infection, what is it another event like a risk of destroying some part of the brain when you insert or disinsert the lead?
So when we insert the lead in the brain, are you asking, does it destroy some of the brain?
Yeah, on the passage of the lead, or I don't know. I have no idea what.
That's actually one of the benefits with DBS. And people often say, how do you avoid certain structures? Do you make a track that's, diagonal, or how do you get in there? We're actually able to preoperatively, we do a really detailed MRI of the brain, and then the morning of surgery, patients have a head frame put on to keep their head still, and then we do a CAT scan with the head frame on, and we have this computerized station called the Stealth Imaging System, and it merges the MRI and the CAT scan and allows us to see an individual patient's brain and then target off that. So we try and avoid structures that we know have a lot of vascularity, like the deep parts, the crevices in the brain or the ventricles. We target to avoid those structures, and then putting the lead in or doing our microelectrode recording, they've found by doing autopsy on patients following, passing and having DBS, that really there's little to no damage done by implanting that lead. The lead, just to give you reference, is 1.2 millimeters in diameter, so it's pretty tiny, and I always say to patients it's pretty little. But yeah, like the tip of a pin, it's pretty little. Or like the other thing I reference is like uncooked angel hair pasta. That's about its shape. but I had a patient about 6 months ago, and I showed it to him, and I said, it's pretty small. And he goes, well, it's not small if it's going into your brain. So he corrected me that maybe it's a little bigger than I recognize, but it really is pretty small. And they do find that there's maybe just 1 or 2 cell layers of what we call gliosis or scarring in the brain. That's microns. I mean, that's just a teeny tiny amount. So, what I try and talk to people about DBS, because, understandably people are wondering, is there other treatment out there? Is there a better treatment that's going to come down the road? But I explain to my patients that I look at DBS as the bridge to get you to those better treatments. I want patients in the best condition they can be in when we have something better, so that they're more likely to be a good candidate for those newer treatments. And with newer treatments, if we need to take the lead out or the entire system out, we can. It's an explantable system if at any point it needs to be. So it's definitely felt to be beneficial in that respect compared to the older technique of lesioning or burning the brain.
Thank you. I have another extra question. When the lead is in place, how do you make sure that it stays in place?
Sure, good question. So we implant the lead using a wire within the lead, a stylet that keeps it nice and straight and in place. And then we have this outer cannula tube that we use. So those things, both in conjunction, help us to get the lead in the correct spot. And then when we take those out, because we've made a little small hole in the brain with the drill, the burr hole, we have a cap system that we place around the hole that we've made with a little locking lead that sits on top, and that serves as 2 functions. 1, to keep that lead right in the location we want it, and then 2, to cover the hole that we made in the skull. So there's very little chance of lead migration or lead movement.
Okay. Did you have any very turbulent patient who it happened? Did you have any incident of the lead displaced in turbulent patient?
Oh, so
or very
do we
active
have any
patient?
incidences of lead migration or the lead moving?
Right.
No,
Yes.
I think at our center, actually, another good question probably to ask your surgeon. It doesn't come up very much at our center because we've been, had very good outcomes. But there's also the potential that obviously if you put the lead in and it's not in the right spot or it moved, you would have to take it out and put it in again. I don't think at our center that we have ever had a lead that we put in that has moved or that we've had to move. We've certainly done that in some instances when we've inherited patients, but the likelihood of that wherever you're going should be very low incidence.
Thank you very much for your good answers.
You're welcome.
Did you have any more questions there at Port Townsend?
I think that's it for us. Thanks so much.
Thank you for your questions. Pullman Regional Hospital, please.
There are 3 of us present today, and I have a question for you. We missed the early part, so you may have of the lecture, so you may have already discussed this. But if a particular patient comes and it's decided to do STN surgery, but later the symptoms change because dominance of symptoms seems to vary with time, can the GPI system be used?
Theoretically, yes. There are some centers in the nation, we don't prescribe to this because certainly when you're in the brain and we do microelectrode recording to figure out the right spot. So we're putting a little teeny tiny needle down in the brain to record the brain before we actually put the lead in place. But anytime you're putting anything in the brain, the more and more times you do it or the more places you do it, the increased potential risk you have for bleed. So we try and minimize that. There have been some centers around the nation that implant 3 or 4 targets all at once. I don't think those patients have any better outcome or long-term likelihood of benefit more so than if you just implanted in one versus the other. And I think what we're finding with both targets from that big study that was done a few years ago is that really either location could probably be the right answer for any patient. It's not like if you implant in the STN or the GPI, something adverse or wrong would happen from that, or that you wouldn't get benefit in your symptoms over time. But theoretically, absolutely. I mean, there could be, we did have a couple of patients back in 98, 99 with Parkinson's and tremor that we implanted in the VIM, that portion of the thalamus, and that just helps tremor. And then when STN came out, they were having, just as you mentioned, they were having more slowness and rigidity and things other than tremor as their disease progressed. And we actually explanted, took it out of the VIM, and put a new lead in the STN with good success. So theoretically, that could be done.
Thank you very much.
You're welcome.
Take care.
Okay, Walla Walla.
Do you have any no question today? Thanks for the presentation.
You're welcome.
Two of us here.
Thank you for joining us. And it looks like I went right over to Nasket. I apologize to Nasket, North Valley Hospital. Okay, and if I have skipped you, go ahead.
This is Coeur d'Alene, and we have 5 people here, and we do have a question.
Welcome, Coeur d'Alene. Go ahead and ask your questions.
Jamie, this is Jack in Coeur d'Alene. Jack.
Oh, hi.
After you tell the people what a great question number 1.
We're having a little hard time hearing you because there's some background, it sounds like, from another site. So if hello, and let's start from the beginning of your question and see if we can speak a little bit louder for us.
Okay. Question number 1. Why isn't there a way to measure the amount of dopamine a person is producing? Apparently there is no way to quantify that. The second part of the question is, have you ever had someone start producing dopamine at a higher level after a while having Parkinson? Or does it always diminish to 0?
Okay, so I think I got it. I think the first question is, why don't we have a better way to quantify how much dopamine a person has in their brain, right?
Correct.
And then the second part is, are you saying after DBS, have I ever had anyone who's had it?
Have you ever begin to produce more dopamine?
Begin to produce it. Okay. Okay. So the first question, we're waiting for you to solve that, and once you do, we'll have a lot more answers. I know you, so I can give you a hard time, Jack.
Yes.
That's one of kind of the mysteries of this disease. We know it's due to a lack of dopamine, and we know that by the time a patient starts to exhibit physical symptoms, they've probably lost 70 to 80% of their dopamine cells. So the majority of the dopamine cells have died at the time that the symptoms present. What we don't know, and what research is heavily looking at, is what causes the cells to die in a patient with Parkinson's, and how much reserve does someone have, or then how quickly do the cells die from that point. You've probably all had experiences where you yourself or you've known people with Parkinson's that has progressed very slowly, and others that have progressed very quickly. And we would assume that that has something to do with the rate of death of the dopamine cells. But you're right, at this point we do not have a good way to quantify that or to understand that any better. And to then look at the second part of the question, do you ever have someone who starts producing dopamine? Again, because we don't have a way to measure it, we wouldn't really know. That's not something we could look at today with not having the ability to measure, truly look at dopamine in the brain. I do have patients with DBS who, 5 years after being implanted, all of a sudden are getting dyskinetic, an indication that they're getting too much medicine or stimulation, and we have to back things down even though no change was made. And it makes you wonder, well, why does that happen? How does that happen? And there are also some people out there that theorize that DBS stimulation or a medication like Comtan may keep the nucleus in the brain more stable, and with it not getting so much pressure and getting that kind of relief from the stimulation, that maybe that preserves the dopamine. And there's some people doing studies looking at, well, is DBS neuroprotective? But at this point, we would say no, we don't believe it is. So I think there's some work being done in that area, but unfortunately we just don't have a very good answer right now.
Thank you.
Thank you.
You're welcome.
And Spokane, do we have any questions today in Spokane? That's okay. There's been an amazing amount of really good questions.
Cindy, this is Tanasket, and there's 4 of us.
Hi there, Tanasket. 4, and did you have questions?
And we had 1 question.
Okay.
Hi.
Well, first of all, I had maybe 2 questions. Do you give an antibiotic before surgery to prevent? Or maybe you said that already, but...
No, I haven't. Very good point. We give IV antibiotic just prior to the surgery, prior to making the incision. And then after the surgery, we do an IV antibiotic. So you get IV antibiotic in the surgery itself. And then we don't, as standard protocol, give everyone antibiotics after that. But if we felt someone is at high risk because they had diabetes or a history of MRSA, methyl-resistant staph, or some indication that puts them at higher risk, then we would prophylactically or preventively use an antibiotic after surgery. But it's not always routine.
Thank you. One more question, but it's about depression. Okay. With Parkinson's, do you have something like a physiological depression just because of the brain changes?
Yeah.
And then,
go ahead.
Well, then that versus like you're depressed because you have, you have a real, you're dealing with a disease. So there's. Sure. But you do have a physiological depression just because of the brain.
They do think that the lack of dopamine itself not only produces the motor symptoms, the tremor, the slowness, stiffness, difficulty walking, but that it can also induce or cause depression, that can be part of it. They used to use dopamine years ago in healthcare, actually, to improve mood, and it made people feel better. So the lack of dopamine absolutely can affect someone's mood.
Okay, thank you.
Okay, and we had a question here in Spokane. Bill, here you go.
Thank you. It was just luck, I guess, today, but I got an email talking about a sleep DBS.
Sure.
I thought when Dr. Carlson was talking about it before, that the people are awake when they do that.
Correct.
What's the difference between the advantage of a sleep DBS?
Sure. So there's kind of this new way. It's really, there's no difference in how we actually do the surgery as far as our imaging, our technique, our protocols. But there's some centers, because our imaging over the years has gotten so good, there's some centers around the country that are doing what's called a sleep DBS. And that can kind of come in a lot of different forms. A sleep DBS could mean someone actually is intubated. And, when you're intubated, your body's paralyzed and you are truly asleep, not moving, don't remember anything. The benefit of that is that people are asleep, and for some people they're worried about the surgery and being awake, so that would obviously be a benefit. The downside is you're relying on imaging as your only verification of your targeting and getting that lead in the right spot. Here in Spokane, and then there's what you hear of like a partial asleep DBS, and that's kind of what ours is. It's not that people are awake the entire time. We give them anesthesia. Oftentimes they get a little bit when we put on the head frame, and then when we're making the incisions and drilling the burr holes, we put people not to the point where they need to be intubated. They're still breathing on their own, but it's kind of a conscious sedation where they're really sleepy and they don't remember it. And then once we're done with that, we turn the anesthesia off, let them fully wake up, and we do microelectrode testing in the brain. And then once we find the correct area, we put the lead in place and we do stimulation testing. So the patient's awake and we're saying, what do you feel? How are you doing? We're looking for tremor suppression, improvement in rigidity, whatever symptoms they may have. So understandably, the thought of being awake during any surgery isn't fun, or maybe what patients want to be thinking about, but there's a difference between the two. And that's the thing about, DBS. I'm sure there are patients out there that think, gosh, I don't want to do this, and being awake might be part of it. But any patient that we've had go through it, and we have some here in the room today who've gone through it that you could ask, I don't think any of them have felt that it's horrific, or at least they don't tell me that. And to make sure we've got the lead in the correct spot and a good outcome, I think to them would be preferable than the idea of being asleep. Not that you can't get the lead in the right spot with a sleep DBS. You can. You're just relying on a little bit less as far as the tools in your toolbox to make sure you get it right where you want it. But you'll be hearing about that more as sleep DBS is kind of gaining more momentum, and something in Spokane that we're certainly looking at as well.
Okay, I think that is it for the day. Thank you so much for all of your great questions. That was one of the reasons I was excited about doing this today, because we did this at the Women with PD here in Spokane, and the amount of discussion afterwards and learning not only about DBS but about Parkinson's was incredible. So thank you very much for joining us in Spokane and all the sites, and look for your postcard for next month on topic and what will be happening coming up here in the next couple of months. Thank you so much.